Okay, I think we're going to go ahead and get started. Thanks everybody for sticking with us until the bitter end. My name is Michael Valera. I'm President and CEO of IHA, and we are co-sponsors of this conference. And I am just humbled and privileged and delighted to introduce our final speaker of the day. Janet O'Henny Frempong has been a friend and colleague of mine for more than 20 years. And if there's anybody who you can say within health literacy, she has been there, seen that, and done that, it's going to be Janet. And you know what I love about this conference is that we have a lot of different individuals speaking within their areas of expertise. I think, you know, all talking about clear, effective communication in plain language. What Janet is going to do in this talk really is kind of go up to a little higher level, bring all of those threads together, and really just drop a little wisdom bomb on all of us here. So I'm going to stop talking, and I'm going to turn it over to our final speaker of the day, Janet O'Henny Frempong.
Michael, thank you so much, and good afternoon, everybody. We're about ready to wind down a bit. But before we do, there's some things I'd like to share with you. I want to let you know that I'm talking to you as a much older woman. Okay, I've been around for a very long time, and that's a good thing, all right? I'm talking to you as a woman. I've seen some things as a woman. I'm talking to you as an African-American. I've seen some things as an African-American, and they all have to do with communicating effectively. I've been married to someone from West Africa for 52 years. So I have an African perspective. I have in-laws who are Guatemalans. I have that perspective too. And all of that's good. And yet and still, when I look at things going on today, I'm worried. I'm worried about how we're communicating with each other, colleagues, clients, how we communicate amongst ourselves. In fact, to some degree, I'm even scared. So I'm going to tell you why. I'm going to bring you through my perspective on things, okay? So we're in an increasingly divided world. I've seen this over the past, I'm almost 75, so a long, long time. I remember how things were a long time ago, and I see how they are now. The question is, how do we communicate effectively in the midst of so much diversity? And where do we find common ground? That's my big question. Where do we find common ground? Because I think we need it. I am giving this closing keynote in memory of two people that I think we all owe our experience to, Len and Cece Doak. Helen Osborne in 2009 did a podcast, or Health Literacy Out Loud, and she said this of them, that they helped lead the way to health literacy, and they did. And they inspired advocates everywhere to improve health understanding. Len passed away in 2012. CC just passed away this August. And I want to let you know, in this coming November, she would have been 100 years old. We owe them a lot. And some of what I'm talking to you about today comes from things that they were telling us way back in 1985, way back in the 1980s. They indicated that comprehension was necessary. Comprehension, understanding stuff, comprehension was necessary, but not sufficient for communicating effectively. They talked about the elements that you want to test with your intended audience before you're done. So when we're talking about involving people, we're talking about human-centered design, yes, also human-centered communication. When we talk about empathy, we're talking about what they were talking about back in 1985. So when we're communicating, what I want to know is what we're saying, what we've done, certainly in print, is it attractive? Do people understand it? Can they show that they can do it? Do they have a sense that this is really meant for them? Was it acceptable? And we'll talk about a little bit more about that in a moment. Was it persuasive? Does it leave you feeling like, yeah, I think this is a great idea? So, point being, comprehension is only one issue. It is really important, but it's not the only thing. And I feel important to say that, not because you all don't know that, because I think you know that, but you're going to deal with people who don't. And you need to be able to point out to them that short words and short sentences are nice. That's nice, but that's not all that there is to that. All right. So again, I'm preaching a bit to the choir, but you will be preaching to people who are not in the choir. And I think you need to be able to say this to them. They stress the importance of reader involvement and the need to run your text and your images past folks. I'm now talking about writing, the people you were hoping to reach before releasing your final message. okay? Sarah Furness, who was responsible for the first health literacy project in this country, said in her introduction to the Dokes 1996 second edition, learner verification and revision uncovers the specific content or format features, sorry, of an instruction that are not understood, yes, understood, but also not accepted, okay? That's my emphasis. And then the process produces remedies, because you can say, oh, they didn't get that or they don't even like it, so let's fix it before we put it out there. However, this can be a special challenge when the folks you are communicating with have so many diverse perspectives, and increasingly so. For example, should I wear a face mask to protect other people or not? Well, we've had 3 years of this conversation. Some people right away said, sure, yeah, absolutely. And other people said, absolutely not going to do that. Right? How do you communicate across this huge divide? All right. So who's hoping to communicate effectively? Well, I'm talking to us. That's us. They're writers, editors, graphic designers, and more. See my little icon down there in writing? He's writing away or she is writing away. They're talking verbally. Nurses, health educators, social workers, and more. Some of them are actually writing and speaking with people at this, also as well. All right. And who has all those diverse perspectives? We're talking about the general public, and they're in different colors because they're different kinds of people. There is this diversity amongst us. And we're supposed to be connecting across some common goal that I've mentioned. What common goal would that be? Well, one of them is a very worthy goal. It's promoting health literacy. And we say that that's what we're doing. All right. But there's an ultimate common goal, I would suggest, and that is promoting health equity. And for the last 2 days, that's really what we've been talking about, doing the kinds of things that bring everybody in, okay? But let's be clear about what that means. Now, there are lots of definitions of health literacy, at least over 20. They're all good and they're functional. Here's mine. It's a simple way of looking at health literacy, I suggest. It's your ability to figure out what's needed for you and for others, your family, other people who you live with, neighbors, people you share the country with. It's your ability to figure out what's needed to stay alive and as well as possible. And I want to point out that staying well includes protecting not only your health, diabetes, hypertension, heart disease, and all that, but also your safety. And for many of us in diverse communities, safety is a huge issue. It's hard to be out there riding around your car, wondering if you're going to get pulled over and have an incident. Safety is an issue, and then your well-being. So there are many routes to promoting health literacy. I love that video of the gentleman from the National Eye Institute. How about some science literacy? That would help. And then, of course, teaching people how to read. Can we at least do that finally? Those things help with promote health literacy. But there's something else that we have responsibility for, and that is the way we communicate, our provider communication. It's one of many routes, but it's an important route, and it's why we're gathered here at this conference. After all, if we don't communicate effectively, and we're talking about X, Y, and Z, and people don't understand us, how in the world will people get the information they need to make informed decisions about how to stay alive and well? People have got to deal with medications. That's complicated. Prevention strategies, they're endless. Discharge instructions, big packets of them. Treatment plans, health insurance form. Yikes, a lot of stuff, okay? So let's launch into this one thing that I want to make. I just want to suggest. Most of us, when we talk about clear communication, we know what we're talking about. We're the in crowd. But for those people who are not part of the in crowd, it might be useful to point out that we're also talking about effective communication. Again, we know this, but some people don't get that, all right? So what's the difference? Let's talk about written communication first. Obviously, we want our written communication to be clear. We want to be of help. When we say, here's what I want you to do in writing, we don't want people to say, what the heck what are they talking about, all right? But we also want our communication to be effective. We want to be of help. So if we say, here's what I want you to do, not only do we want people to understand, we don't want them to start snoring and drooling because we bored them to death, okay? There are ways to make things interesting, and we know what they are. We want them to say, no way, or how dare you, right? We don't want to insult, bore, alienate people, okay? And we know what to do. We know how to make information clear. We know how to make it easy to find. We know how to make it look easy to read. We know how to actually make it be easy to read or decode. We know even how to make it easy to understand and even act upon, all of those things. We use layout, we design, we use navigation if it's on the web. We have our text, we have our illustrations. We're actually pretty darn good at what we do, okay? But we also want to make it easy to relate to. So we want to make something seem personally relevant, believable, practical, persuasive and convincing, acceptable and non-offensive. And this is what Len and Cece were talking about way back in 1985. We have to bring that message in with us into the 21st century, because some people still don't get that. You get a client, they say, oh, we just want short words and sentences. Well, no, we're going to need to do some consumer research, and we're going to talk about this later on. We have our biases. Each of us has biases. We're probably going to need to control them because they're very sneaky. They can sneak up on you, okay? Especially we want to make things non-offensive, because people are offended these days like you won't imagine. Everybody's touchy about a lot of stuff. We're practically at each other's throats, and that's kind of an understatement. For example, here's a booklet that we did, actually it was some time ago. It's for people who have diabetes and who are living in shelters and transitional housing, and they face many, many barriers, okay? So we went to talk to them because we were concerned about them and how they were doing. Managing diabetes is not easy on a good day in your own house with no problems, okay? But if you're in a shelter, you've got to have some, potentially, hopefully extra support. So of course we tried with layout and design to make information easy to find, look it easy to read. We want to have walls of text. We wanted to make it actually easy to read, not big, long words and long sentences. But here's the tricky part. Conceptual appeal. How do we make this appealing? You're in a homeless shelter. I mean, you can tell people what to do. All right, you're in a homeless shelter and you've got diabetes. Here's what to do. But we didn't want to be taskmasters. We wanted to be cheerleaders. We wanted to give people a message of hope and respect. So we said, I'm going to be okay. How to deal with diabetes until you get a place of your own. I will tell you, some people will never get a place of their own, and some people will not be okay. But that's not what we want to communicate. We want to give people a sense of hope and, very importantly, a sense of respect. So we go inside the book. Here's a table of contents, fairly thorough, but simple. We didn't want to leave things out because they need this information. Living with diabetes, blood sugars up and down. What else can we do to stay well besides all of these things? But we asked people who were residents, what gets in the way? What is it that makes it hard for them? And so that's what we focused on. I'm just going to show you this. We also put in pictures because they said, we want to see ourselves. Okay. So what gets in the way? Here's some things that they said. No choices at mealtime. They can't just be in their own house and say, okay, I want this or I want that. They have to eat what they've been served. Not having enough money, that's a problem for a lot of people, even if you're not in a shelter, but certainly there. Not having your diabetes supply. Some people have lost them in the transition from one place to the next. Being stressed and depressed, not having health insurance. So we enumerated those. They told us what got in the way. Let's just take a look at what they said about not having enough money. So we have a nice header here. We've segmented it. What gets in the way? You can't afford to buy food for yourself and a different food for your family. Here's what you can do. And we gave them a number of things to do. But here's what we really tried to say, because people said, they think that just because we're in a homeless shelter, that we just don't care about what we feed our children and what we feed ourselves. But we do. One woman, I remember her saying, I really want to have brown rice. And I want to have, organic foods, and I want to have more fruits and vegetables. And so we have to listen to those voices and not think that just because you may have some bias, well, they're in some homeless shelter and they're going to love whatever they've given. Not necessarily the case. So not having enough money, here's what we said. Decide how to spend the money you have. Some foods are better for you than others. That's a fact, all right? But you have choices. Some cost less, some cost more. The problem is that the best choices of foods may cost more. They may be heavier to carry and harder to keep. Try carting around fresh produce, okay? You may not even like the way they taste. But here's the hint. But you should at least know the difference so you can make your own choices. It's your money, it's your health and your family's health, and you have the right to make your own choices. Hopefully you can just see how this could be a very slippery slope if we miss these kinds of messaging. We can be very, very clear. We can give them a list of all the cheap foods to buy and leave them feeling insulted and disconnected, bored, and just like, you really don't hear us, okay? But this is a measure of respect and regard. And when we went back and asked, tested this book, people literally said, we feel this was just for us. And it was, because we did listen to them. Okay, so that's written communication. Verbal communication, we have similar concerns. We want it to be clear. We want to be helpful. So you say, as I was saying, and somebody saying, huh, what are you saying? Can you get it together? We want to be clear, but we also want to be effective. We don't want to bore people. We don't want to put them to sleep. We don't want them to say, this is not for me, save your breath, or how insensitive. That's not our goal. So the Health Literacy Universal Precautions Toolkit, which is one of the most wonderful additions to our field, gives us strategies for communicating clearly. Use plain non-medical language. These are for people who are communicating on the phone or maybe face-to-face. Use the patient's words. Listen to how they're talking about things. Slow down. Limit and repeat content. Be specific and concrete. And all of this is easier said than done when you're in a clinic setting and people are sitting out in the waiting room waiting for you to see them next. If you can show graphics, that helps. Invite patient participation. Some people are long-winded and you don't even want to invite that because they'll tell you their whole life story. But these are important. Encourage questions and listen to this. Teach back was huge. This is a biggie because we used to say, do you understand? And people say yes. You say, well, do you have any questions? And they'd say no. So we thought, we've got a better idea. If you had to go home and explain this to your family, what would you tell them about your medication, your exercise? Teach it back. Check for understanding, okay? That's what we're really looking for. Did they get it? We put it down, did they pick it up? But there's some other things that I think sometimes we might leave out because we can also check for feasibility. Some people may understand, but they may not be able to actually follow through. So we can ask things like, what, if anything, might you have a hard time doing? Even if you want to, what, if anything, might get in the way? And somebody may say, look, I get you, doc, but I work long hours and I'm usually too tired to exercise every day. Or somebody may say, my neighborhood is a mess. I can't go outside my door without being, afraid for my safety. Okay. Another thing that we can do is ask for it, check for acceptance. Some people may want to, they may understand it, they may actually be able to do it, but they may decide, I don't know. What, if anything, may seem either hard to accept or maybe even hard to believe? We can ask that. Now, it takes more time, I understand. But if you can ask that, you can say, what, if anything, might worry you enough to think about doing things differently? Maybe there's a better way of saying that, but maybe that's one way. And somebody may say, I read that medicine can cause a lot of bad side effects, and I'm scared to take it. And I'm not sure I really will. People really don't want to tell you that. But if you check for acceptance, they might just do so, okay? That means you're even more effective. You're not just being clear, but you're really getting into the nitty-gritty. So you may say, okay, so I see the difference between being clear and effective. And again, we're insiders. We can talk about clear. We know what we're talking about. But if you're bringing somebody into the field or you've got a client and you're trying to, you have to help, this might help them understand the difference between short words and sentences and something that's much more important. So we've gone through some of these tips. We know things that we're supposed to do, but guess what? There's more. We also want to promote health equity, do we not? So what does that mean? We have to know what we're talking about in order to promote it. Health equity means that everyone, and this is my emphasis, and this is from Robert Wood Johnson. They have really the most lovely definition of health equity. There are a lot of them, but I like theirs. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. And I might say just to stay alive, because that's an issue these days. Staying alive is actually a big deal, especially for some of us. All right. This requires, they go on to say, removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to a whole slew of things, good jobs with fair pay, quality education, quality housing, safe environments, and healthcare. And here we have, I'm just going to add one more thing, accessible transportation. Now that we could go into the weeds and we can talk, I mean, there's social justice, criminal justice reform, and all that. I just decided to keep it a little bit lighter today, because if we go there, I'm going to get on some kind of, what do you call it, soapbox, and you'll never get home for the weekend. But these are things that we think everybody should have a fair and just opportunity. What you do with them is another thing, but can we at least have a shot at it, an equal chance? But everyone doesn't. Everyone does not have an equal chance at this. And so we have a conundrum. We have a lot of inequities, all right? This thing just dropped down and I can't read what this is. Because, where did it go? Hold on, I'm sorry, I'm trying to get this thing to go away. And I'm scared to click it because then I might lose you. Because some people have been historically oppressed, targeted, and or neglected. And it's not just African Americans. Just want to make that clear. We tend to take center stage because boy, have we ever been through the mill. And some of these are overlapping. You can be in more than one, oppressed, targeted, or neglected group, in which case your life is rough. But we're talking about people in corrections and detention, people with a disability, people with a substance abuse disorder, people who have limited access to all kinds of things that can help them stay alive and well, people who are experiencing homelessness, people with lower incomes, and there's more, people with a mental illness. Think about this: oppressed, targeted, and or neglected, people who are immigrants, older adults, people who are at increased or higher risk for certain conditions. You can probably think of some of those right off the top of your head. Targeted, neglected, ostracized even. People based on their race and ethnicity. Well, that's a no-brainer. We know how that goes. And then you've got people based on their sexual orientation and gender identity. That's a big knockdown, drag out issue these days and always has been. But we're dealing with these things. So now we're talking about social justice, are we? Yep, yes, we are. And social inequities are pervasive and entrenched. And they affect so many different kinds of people. I really want to point out, African Americans are not the only people who are having a hard time here. There are a lot of people who are experiencing this. But we're here to talk about effective communication. So what does this have to do with how we're communicating with each other? What does that have to do? Seem like you're going off on a tangent? Well, remember, we want to avoid having to either inadvertently, because we don't mean to, bore, alienate, or insult people. But these long-standing inequities and so forth can affect the way we think. Think about this. We're all part of this. We're not separate. This is society we live in. This is the world we live in. And these things, they affect the way each of us thinks, the way each of us treats each other. And also, it affects the things we say. It affects the words we write. Here's what I want you to do. Remember, how dare you? The visuals we show. Show two men kissing and see what some people are going to say. They're going to have a complete conniption. All right? But now that's what we're seeing. Most people have some biased perceptions about others. Most of us do. Those drug addicts, those homeless people, or the homeless people, all right? The word bias refers to a negative or even a positive idea. These people are so smart, we know you're smart because you're one of those. A person has something or someone or something. A person's bias can affect how they interact with people of certain groups. Implicit bias is a scary one because that's the bias that someone's unaware of. And a person who has implicit bias, and that's probably each of us, may believe that they treat everyone equally. Okay, but if you've been around for a while, that may not be the case. All right. However, the person's implicit bias may cause unconscious negative associations towards certain groups of people. You've got your coming with your biased perceptions. You're saying, yeah, he's an addict. Well, now he's homeless. All right. And these are what some of us have experienced. Many of us, microaggressions. That's a word that's been around for a while, but we're hearing it more and more. These are everyday verbal, nonverbal, environmental slights, snubs, or insults, whether intentional or unintentional, which communicate hostile, derogatory, negative messages to target persons based solely upon their marginalized group membership. So, what can we do? We can talk about them, but what are we supposed to do? What we can do if we care, and we do. I am sure that I'm caring for people who are, anyone who's still here, you care, all right? It's 2 full days. We'll try to avoid unintentionally doing any of those things, especially with regard to the following issues. Culture. This is nothing new. We've been talking about cultural sensitivity and cultural humility for decades now. All right, there've been books written about it, and we've included culture in with our, health literacy. All right, cultural sensitivity. Trauma, though, is relatively new. So using trauma-informed and trauma-sensitive language is something that now we're having to stop and think about. So when we're talking about trauma, who are we talking about? People who look just like you and me. They may be smiling, they may be doing, looking okay, dressed all nice, hair all done. You don't know what they've seen. Physical, sexual, and emotional abuse. What have they experienced? Childhood neglect, violence in the community, violence while serving in the military. That's where we think, oh, PTSD. But there are other types of trauma. Having a family member with a mental health problem or a substance use disorder. And then, of course, there is the trauma of poverty and systemic discrimination. That's deep. So let's talk about social exclusion. People who have been excluded. You all stay over there. We're going to put you in this reservation. We're going to put you in this ghetto. We're going to put you in this little place of town. Everybody else is going to be all right, but the rest of all, you just stay over there. That's called exclusion. For people from historically oppressed, targeted, or neglected groups, we want, as writers, as designers, and as editors who oversee the whole process, those of us who are speaking to people, to minimize implicit bias and any resulted yet unintended microaggressions. That's what we're trying to do. We want to promote inclusion and equity. We don't want to be a part of making any other person feel looked down upon, left out, not seen, not heard, especially when they are trying to stay alive and well. They're seeking information, service, and or care, all right, that they need to stay alive and well as possible. That's what we're here to do. We want to keep people alive and well. We don't want to make them miserable and feel awful, excluded. We want people to be included, okay? So that's how we want to speak, in ways that promote including. Okay, all right, so we're caring people, so how hard could this be? After all, we like everybody, we care, and we understand all these things. So let's just talk about this. What can we do to minimize unintended biases and perceived microaggressions? Because guess what? Shifting every day almost, norms. What we were used to before, what we used to today, I think by tomorrow is going to be a little bit different. So let's turn to the CDC and see what they have to say, because after all, we're in healthcare, so we want to talk about, things that have to do with health. CDC has been giving us guidance on preferred terms for selected population groups and communities. Now, I'm going to breeze through this because we could talk about this all day long, but I'm going to give you some examples, all right? Remember those groups that I told you about before? Corrections and detention. All right, here's what the CDC says. Specifically, for corrections and detention, if you want to be respectful to persons who've been incarcerated, maybe we could stop calling them inmates. We can call them, say he's not an inmate. He's a person he was someone who was incarcerated. He's not an ex-con, okay? He's a returning citizen or a person who was formerly incarcerated, okay? She's not disabled. She's a person she has a disability. She's not disabled, she's a person with a disability. Person first, person first. And what the CDC does, and these are just, this is the top of the line. You really ought to go to this, the website's there. Because you know what a person calls himself, herself, themselves, that's their business. But when we're talking about people, these are the kinds of nuances we need to be aware of, okay? So that we can do the things we said we want to do, be inclusive, use inclusive language, not the drug user, the drug addict, all right? A person who has a substance abuse disorder. Now, at this point, some people are going to be rolling their eyes and like, oh, come on, please, do we really have to do? Yeah. These are things we need to think about because it helps. We can talk about underserved communities. We've been doing this for a long time. We can say these are people who are underserved, people who live and work in citizens, you know, that put them in high risk for becoming infected or exposed to however we want to be specific about it. People, not the homeless, but people experiencing homelessness. Not the lower income people, but people with lower incomes. Not the mentally ill, but people with a mental illness. He's mentally ill. No, he's someone who has a mental illness. Not that illegal immigrant. This is someone with undocumented status. And don't call me senior, because I'm not going to be no senior citizen. I'll tell you that right now. I'm an older adult, grown woman, not trying to have it. Don't call me the elderly or anything. You know, maybe somebody, not me. Don't do it. Okay. Not frail or fragile yet. Now, some people are. Okay. But we're grown people, high risk people, people who are at increased risk for whatever. Oh, I've got a typo there. And then, of course, here we go. The blacks, the Hispanics, the whites, the American Indians, etc. Okay, how about a black or an African-American person? How about a white person? All right. And for ethnic groups, all right, not the Hispanics, but Hispanic or Latino people. All right. Even rural people, because sometimes I can kind of have a little, oh, you know, you hick people over there, right? Rural people, these are people who live in rural, sparsely populated areas. Homosexual is out. LGBTQ plus is way in. We don't just go around calling people all kinds of names. And this one, you have to actually perk up and pay attention because there are many new terms that more effectively capture what people who people want to be. Then we have he or she, he, she, his, her. No, not anymore. Singular, they or their. He, she, or they. Okay. Breastfeeding. We now have chest feeding. We might want to remember that when we're talking about breastfeeding. But there's more. Because what CDC did not deal with was overweight, obese, fat. People hate that stuff. They hate being called obese and overweight. They get highly offended. They don't like it one bit. And it's really, you really can't find some labels. Some people say I'm big bone, you know, I'm plump. This, I caution you, it's not a good idea to start calling people those names. You can talk about body mass index. If people understand it, you can ask people, how do you feel about your weight? Or you cannot bring it up. If you're not the person's doctor and you have no business asking, then you can just say, let's not go there. And then, of course, you have the more gender inclusive terminology. Mankind, that was such a nice word, mankind. Oh, all of mankind. Well, no. How about human beings or humanity? The common man. How about the average ordinary person? It's not the mailman, it's the mail carrier. That's not the policeman. It's now the police officer. It's not the stewardess, it's the flight attendant. We're making progress. But gee whiz, cheese and crackers, this may not always be so easy. And I wonder if I may have some biases of my own. Anyway, the old terms may be familiar and somewhat clear. Ladies and gentlemen, senior citizens, the homosexuals, mankind, the overweight. We can say that, but people are like, what? Excuse me, please. I don't think so. So I definitely care, but what if I make a mistake? This is the way I've been talking for a long time. All right. And this kind of reminds me now, don't think I'm making fun because I'm not, but I couldn't help this. It reminds me of an old poem that goes like this, because this was a cute one. I used to read this to my kids, but then I thought about it, my kids and my grandkids. Listen to this. A centipede was happy quite until a toad in fun said, a prey, which leg comes after which threw her mind in such a pitch. She lay bewildered in the ditch, considering how to run. Look at her, she's saying, what? I got all these legs, what am I supposed to do? This is the centipede's dilemma. It raises the fact that conscious attention to a task that is usually performed automatically can make it difficult to perform. Humphrey's law states that if a person has acquired enough skill to do something automatically, the mere act of stopping to think about it can end up being detrimental to the task execution. So if she lay bewildered in a ditch considering how to run, think about us. Suppose you want to get from, your bed to the refrigerator and you had to do this. You may take you a moment to figure out. You just get up and walk. Usually we just start talking, but we may need to think before we speak. We may need to think before we write. Okay? Because where are we trying? What's our goal? Effective communication. Problem is, but choosing the right words these days may begin to feel like walking on eggs. However, as we continue to make this effort, we may begin to find that we are really walking on solid ground once again. So for example, all right, instead of saying this, underserved communities, the senior citizens, the mankind, we're talking about humanity, people who are Hispanic, the LGBTQ community. We're talking about everyone, not just good evening, ladies and gentlemen, but good evening, everyone. Okay. All right. Let me try to pull this all together. Why am I saying all of these things to you? I'll tell you why, because I'm scared. I really am. We are talking about microaggressions, and I get it. I've experienced them. Oh, you talk so eloquently. Yeah, thank you. I'm so glad that you think so. Right? The things that scare me are the microaggressions, the macro ones, the big ones that can undermine the efforts to support diversity, equity, inclusion, which is what we're trying to do. And that can actually threaten our very lives. So we're trying to do our best, okay? And somebody says, oh, much better. Good, get an A, you're doing much better. All right, how about this? Here's what I mean. Or while people are trying to do the best, we can get offended with those who are trying to be respectful, supportive, but falter as they try to find their way. You can make a mistake and you can say, listen, I don't like that. And you can fuss and feud about it. All right. All right. They're trying to be, hey, there's going to be health care for senior citizens. And I'm thinking, I'm not some senior citizen. You mean older adults? You mean grown folks? Okay. We can get offended and try, or we can actually, okay, until we each find some solid ground, we can get offended, or we can make an effort to find some common ground, try to grant some folks some leeway and maybe even encouragement. Now, some of you aren't going to like this. I know this. You're going to say, look, what are we asking you to do? People are sitting there offending us, and we're going to try to give them leeway and encouragement. But consider this, all right? The truth is that many people are understandably tired and touchy, and so they are really, really not trying to, have these microaggressions aimed at them. They have been through unimaginable trauma and stress, and maybe some other reasons, sometimes personality. Some people are very, very highly sensitive. So it's going to be a problem for some people to grant grace. Others, however, may have the forbearance to be understanding and to explain. And it partly depends on personality, one's past experiences with exclusion. But some things that we could do if we wanted to grant some grace is to say, ask for clarification or more information. Acknowledge the feelings behind the statement. Separate the intent from the impact. Did she really mean to, this is my friend, she's saying this to me. Share your own process, because you probably have some issues yourself. Express your feelings. If you can do it nicely, that's even better. Challenge the stereotype. Appeal to values and principles. And we talked about this earlier, it was yesterday, I think, empathy. Empathy is a huge one. But why bother? And here's where we get into the nitty-gritty. And I'm going to try to wrap this up, because here's what scares me. Somebody says, don't forget what your people have done and still do to my people. Now that's African Americans, but they're not the only ones. They're not the only ones, all right? But since I'm African American, I'm gonna just camp out right here. Somebody says, I know, and it still is, it's awful. So let's do something about it. So I'm thinking, all right, so, they're a little bit off track, but they're really on my side, okay? I want you to read this quote. This comes from Don Ross, Tulsa, Oklahoma, Tulsa. And if you remember Tulsa and what happened in Tulsa, this is a guy from Tulsa, remembering the history of what happened, the brutality. Civil rights activist and journalist says it well. He says, none of us is guilty for the sins of our fathers, but we are responsible for how we react to the evils that were done. Okay? What we are looking for really, I think, should not be guilt, not guilt tripping. It trips people up. That's why it's called a guilt trip. That's another term for trip. But awareness, we want people to be aware, to be concerned, to take action. For me, I'm African American. I need some awareness, some concern, and some action about how people in the LGBT community have been treated, how Jewish people were treated in the past, how people with disabilities have been treated. And also, because even if you haven't adjusted your words and thoughts yet, and don't call us that, gee, help me out. I really do want to be helpful, somebody's saying. But here's one of the things that really frightens me, is that you've got people who really are on our side and they want to help, but then there are people who clearly do not. And this is where my focus is these days, because I see it. It's hard for me even to watch TV or listen to the radio anymore because of the hatred, the vitriol, and the violence. We people are in the midst of a raging culture war in this country. And trust me, I'm still talking about communication, so just fasten your seatbelts. Meaning a cultural conflict between social groups and the struggle for dominance of their values, beliefs, and practices, what we value, what we believe in, what we want to do with each other and ourselves. The term commonly refers to topics on which there's general societal disagreement and polarization in societal values. Some of us saying, yeah, let's include everybody. Let's bring everybody along. LGBTQ, Black folks, Asian people. Are you kidding? No, we don't want them around. We don't like them. Here, this was an experience I had just a couple of weeks ago. Healthcare systems are trying to be more inclusive. Here's a medical waiting room. Person who's in charge of the waiting says, listen, please fill out the registration forms. And here's what the registration form said. What is your current gender identity? Check all that apply. Male, female, transgender male, transgender female, gender queer, additional category, please specify. That was the first question. Second one is, what gender were you assigned at birth? Male, female, other, or you declined to answer. So this is me. I'm saying, oh, how nice. Finally, they're including people. This is really cool. They've got this down here. I'm very proud of my healthcare system. Behind me, somebody says, this is crazy. Are these people nuts? Not everybody's with us, but our healthcare institutions, at least the ones I know, they're trying. Our NGOs and NPOs, they're trying too. Look, the Joint Commission, the National Committee for Quality Assurance, NCQA, the National Academy of Medicine that used to be the IOM, they're on our side. You can read their stuff. They're great. And then you've got the White House and you've got the Congress. We need them on our side too, if we're really fighting for inclusion and health equity and all those good, juicy things. But guess what? Not all White Houses are going to be on our side. And the future, the road lies ahead. We have to decide what we're going to have. Here is the Legal Defense Fund statement on revocation of the previous president's administration on anti-diversity executive order. They did this. We had the election, we think, and then in January 2021, here's what the Legal Defense Fund said, and they voted for this. They were fighting for inclusion. It says that the president, today, the new president issued an executive order revoking the prior president's administration executive order on combating race and stereotyping issued in September of 2020. In 2020, we got this order that says, listen, you can't come to this federal government as a contractor and just be talking about all that inclusion stuff. You can't do that. The now revoked order took aim at federal agencies, U.S. military institutions, grant recipients, and contractors, forbidding them for engaging in speech activities, including workplace trainings. Can you come and do training for our workplace? No, you can't. And if you're going to be promoting diversity, equity, inclusion, forget it. And it was conditioning federal funding, which some of you are looking for, grants, on adherence to prescribed ahistorical belief system. I'm saying it because it needs to be said. So we've got a new White House. Here's what the executive order on advancing racial equity and support for underserved communities through federal government. This is the White House in 2020. Equal opportunity is the bedrock of American democracy, and our diversity is one of our country's greatest strengths. He talked about people who are often denied equal opportunity. You should read this, it's beautifully done. He talked about the climate crises and all of these other kinds of crises have exposed and exacerbated inequities, while a historic movement for justice has highlighted unbearable human cost of systemic racism and so forth. So this new executive order will be advancing equity for all, and not only for people of color, but also those who have been historically underserved, marginalized, and adversely affected by persistent poverty and inequality. So who does that affect? A whole bunch of people. The CDC, the Centers for Medicare and Medicaid Services, NIH, HRSA, ARC, FDA, and OSHA. These are all federal agencies. So if you care about this, your federal government better be behind you. It affects us, the writers, editors, graphic designers, the nurses, the health educators, so certainly the researchers upon whose shoulders we stand. They look for federal grants, and they may or may not get them. It can affect our intended audiences and make them feel either excluded or included, our general public. Okay? We don't want people to feel excluded. So let me just run this by you one more time. I'm going to have to zip along and see if I can get through this, and I think I can. Different colors for different folks. Those based, who has been excluded? Those based on age and income vulnerability, older adults and people with lower incomes. Gender, women and LGBTQ community. Race and ethnicity, everybody. African, Middle Eastern, North Asian, South Asian, Southeast Asian, Oceanic, mixed ancestry. Now there's some people who used to be discriminated against, they've managed to assimilate. Southern European, Greeks, Italians, they caught a really hard time. Poles, Irish, Scottish, they had a very, very rough time before, okay? Then you have religion, people who are Jewish, people who are Muslim, people who are atheists. People are based on physical appearance, disabled, physically disfigured, overweight, okay? Perceived as being overweight. People who were perceived as being short in stature. And last but far from least, people who are white. Why them? You think they're the only ones who are on the other side? No. People who respect, befriend, and advocate or defend any other historically oppressed target or neglected group, and who are promoting diversity, equity, inclusion. They're on the side of inclusion. So we have all this diversity. This is, this is us and the people that we serve. And what do we have in common? We have our humanity. That's what brings us together. And each of us who wants their own one group to be included should think about the other groups. My group has been oppressed, but what about the other group? Are you helping them out too? I think we should. That's my opinion. You may not agree, but I think if you want it for yourself, you may want to unite across all forms of human diversity. Like that. Because this I'm calling blue a shared value, a value of inclusion. And I put a little eye on our chest, or in the chest of people who are part of this group. And it also means promoting these things. Some value inclusion. It depends on what you value. Some may value exclusion for many. Some want inclusion for all. Some value exclusion for many. This is the group that Some of us here, I think, at least I've listened to you for the last 2 days, you want that, but then some people don't. They want it only for themselves. Now, don't forget the purple people, because that may be some of us. That's nice for me, but those other people, I'm not too sure about them. We need to think about that. I really think we need to revisit this position. And I'm adding some other things. Stereotypes have been perpetrated against so many different kinds of people: radio, television, the movies, magazines, newspapers, and yes, history books, which they are now in the process of burning. Okay. Tensions have mounted over this issue. Some people tell you, look, I just don't like y'all. Don't like you people. All right. Some want inclusion, others don't. Include, don't exclude. Some people have become violent. This is what worries me. The macro aggressions. Okay. Some have gone from not, unintentional microaggressions, but deliberate microaggressions to actual violent microaggressions. So it may be time to give people who actually are on our side, they're all blue, a little bit of grace, okay? They may be committing unintended microaggressions. I think we can help them along, help each other along. Because if we don't, here's my concern. This is what will happen to us. I think it's time for us to unite around this issue of diversity, equity, and inclusion. All of us, okay? And all of us who have faced exclusion of one type or another, Jewish people, Muslim people, we need to help each other out. Okay. Women who were white had to fight hard to get the right to vote. And they did. Yay, women. Okay, as a woman, can you imagine what life would be like if we couldn't vote today? But they left out Black women, all right? So we had the Seneca Falls Convention that set off, but it left out Black women. Then Mary Church Terrell and the others of the National Association of Colored Women, partly in response to racism at white women's suffrages, they said, we're still voting for, we need our voting rights too. So they didn't come together. That would have been a big deal back then, but they didn't. Missed opportunity, all women. But I remember this. I was old enough to remember this. I was probably around 12, 14 these days. Look at all these different people. There's not just Black people asking for a right to vote. Look at these white women. Look at the white men. They were with us. Jewish people, Muslim people, they came. They stood with us. They died for us. Andrew Goodman, Michael Schwerner. They were from New York City, 2 Jewish boys. They came down to fight for this Freedom Summer. And the Ku Klux Klan killed them. We're still talking about communication. You may think I'm not, but I am. I'm talking about sticking together because I stood in front of these water fountains. I am actually that old. I remember this. And I remember my aunt saying, don't you even think about taking anything other than what has been asked us to do. We will be in trouble. I was in Atlanta, Georgia, and she told me that. I will never forget it. This is exclusion. This is what it looks like. This is not just an issue for the United States. It's a global issue. It's taking place in Brazil. It's taking place in Africa. It's taking place all over the world. But there's hope. And if I have to finish with this, this is what I'll do. Look at this. When George Floyd passed, when he was executed, Norway is basically a white country, but look how they came out. People who are Black standing up for people who are Asian. Stop Asian hate. Look at that. Asians standing up for us, for Black folks. All right. And that's my term, people who are Black. Brown and Black, Asian solidarity, love and unity over hate and apathy. Look at this. Cross-cultural solidarity, Asians for Black lives, no justice, no peace. Okay, if you can see it, you can be it. Young Asians, Latinos, Unidos con Black Lives Matter. Asians and Latinos, and Latinos and Blacks united. All right, the United Way of Central Oregon. Protest demanding racial justice. LGBT community should stand up for Black rights. And vice versa. Muslim groups show support for Jewish community after Dallas hostage crisis. And Muslims and Jews get together to fight hate crimes. Jews donating to fix a mosque after an arson hate attack. And here's a chemistry professor who is inviting everybody in their class to get together and let them know that everyone is welcome here. So from health communication to social justice, is this what we signed up for? Well, again, who are we hoping to communicate? Who's hoping to communicate effectively? Back to us. And who are we hoping to communicate effectively with? The general public. And what are we looking for? Health literacy and health equity. So we're back where we started. So let me just zoom through this. Give me just 5 more minutes and let me do this. So where do we stand? Supporting inclusion, I agree, I hope you do. And how might we be able to do that? Trying to remember, because it's kind of complimented. Let's see. I'll leave you with this. This means that as providers of information, service, and care, we're not only thinking about whether or not people understand, but also whether or not it's effective, all right? We want to take in different perspectives from yours, from the cultural background, trauma, people who are oppressed, targeted, and neglected. We have to stop and think and think before we speak, think before we write, use inclusive terms and language. And this is important for those of us who are from those historically oppressed, targeted, and neglected group. Jewish people, Muslim people, Black people, Asian people, the Native, the original communities of people who lived in this country before everybody else showed up. All right, we can either get offended, which we can understand if we are, or we can encourage inclusion instead of a rebuff. Okay, all right, and we want to think about supporting other groups that are historically oppressed and targeted and not just our own, okay? We might consider sticking together, okay? And I will end with this, that effectively promoting health literacy and health equity involves more than finding the right words or even involving our intended audiences. It involves promoting the aspirational values expressed in the US Pledge of Allegiance, of liberty and justice for all. And so we can vote for elected officials who value diversity, equity, and inclusion. Oh, so now we're talking about elected officials. We're talking about civic literacy. Now, for those of you who know, we talked about civic literacy a couple of years ago. I've been a little bit absent, gone through some things with my own family, but this seems like a stretch, so let me just tie it together because it really isn't a stretch. Let me point this out. We're in October, November is coming. Here's a parting message to you. Way back in 2005, not too long after the anthrax attacks of 2001, Zarkadulis, Pleasant, and Greer released an article entitled, Understanding Health Literacy in Expanded Model. And here's what they said. Their model suggested that becoming functionally health literacy, and I really hope each of you finds this article and reads it, requires some abilities or 4 central domains, really different types of literacy. There's fundamental literacy, that's reading and writing, science literacy, cultural literacy, but they really talked about civic literacy, and that's what I want to talk about in closing. They said that civic literacy refers to the abilities that enable citizens to become aware of public issues and become involved in the decision-making process. Being awareness that individual decisions can impact public health, all right, wearing face masks, where you get your news, so media literacy, we've had sessions on that. And finally, but last but not least, who should I vote for? The question is, who will help us keep alive and who will keep us well? Are we aware of these public issues and how do we get involved? Because somebody will say, I'm for this way, and another person will say, I'm for that way. And what we have to do is to vote our values. Because what do we want? Do we want a nation divided with liberty and justice for some, rich, white, Christian, and healthy? For one, poor, non-white, non-Christian, and infirm for others? Or do we want one nation indivisible with liberty and justice for all? In 2022, it is increasingly a binary choice. These are my last few slides. So I suggest that we pick a side and stick together. Stick together. Because it is no longer, just as in 2020, it is no longer a choice between dawn, the sun coming up, and dusk, the sun going down. It is now a choice between day and night. And if night prevails, my question to each of you is, where will that lead us? So let me leave you in your closing sessions. I'm 2 minutes over with Cynthia Bauer, who is the director of the Horowitz Center for Health Literacy, and Michael Valere, who is the executive director for the Institute for Healthcare Advancement. And let you take it away. Pardon my 2 minute overtime.
No, you're fine. Thank you, Janet. And I just wanted to say thank you. I was monitoring the chat comments. There's a lot of really rich comments in there. So if you're able to take a look at some of those, please do. We don't have a ton of questions here. There was just one person asking about other tools that are out there other than the CDC guidelines to help evaluate language biases. Maybe we could just table that question and we can see if we can find some additional.
The answer is yes, lots. There's tons.
Oh.
I just stuck with the CDC because it's a unifying agency. Right. Yeah.
So again, I think Janet gave us all one of those reminders that it's always great to get about really pull back a little bit and understand who we are, where we are, and especially where we are in context with other people. And you gave us an awful lot to think about. I think I'll need to watch that session again when it's recorded and posted, because there's plenty for us to really think about and understand here. So Janet, thank you very much for that. Somebody just said in the comments that if this was a live presentation, you'd be getting a standing ovation right now. And I completely
Oh, good.
agree.
Let it be useful. Let it be useful. Let's stick together.
Thank you very much. We are going to go ahead and move on to our closing session, and we're going to try to just stay on time. We've got about 12 more minutes here. Cynthia, I'll open it up to you if you want to start off with some final comments here for the capping off our conference.
Great, thank you, Michael. Yeah, so I've been thinking about a couple of things, both coming into the conference and then, what's been happening over the last couple of days. I think one thing is just kind of reflecting on the maturity of health literacy as an area of research and practice. You and I have been at this work a long time, but I was thinking the other day that we're almost coming up on the 20-year anniversary of the Institute of Medicine report in 2004. And that's quite a milestone, right? Because I remember, what a big deal it was when that report came out. Same thing, National Action Plan to Improve Health Literacy that you gave me a platform to talk about. It's now 12 years old, right? Yeah, it came out in 2010. So, there's a number of things. I think we had a session from some National Library of Medicine researchers that were talking about health information quality criteria. That work is that's 22 years old now, or older, maybe 25 at this point. So I think there's an interesting maturity, and this conference, I think, looked back in a couple of sessions, but I think also was very innovative. I think there was a lot of innovation that was presented. I was very excited by the session that we had on Black adults and digital mental health apps, on Monifa Von Cook's presentation this morning on trends and new developments, as well as some cautionary factors for digital health. I think, we just finished a session right before this on some innovations that we've been trying in evidence-based diabetes lifestyle change program. So I just feel really excited about where health literacy is at the moment, because I feel like we've got enough behind us to know what we're doing, but there's some really cool innovation. I think there's some opportunities to take things to scale, which those of you who have heard me talk before, I'm a big believer that we can't have small solutions anymore. We need big solutions for big problems. If we're talking about health literacy as a society-wide problem, then we need society-wide solutions. So I'm kind of excited by what we've been talking about the last 2 days, because I feel like we're pointed in the right direction.
You know, absolutely. I couldn't agree with you more. And, you know, I keep the song that keeps going through my mind is that old Roxy Music song, More Than This, right? Because you're right. I mean, health literacy really has become so much more. And I think Janet's talk really reminded us a lot of that. You know, it used to be if like when I would sit down and rewrite a document, somebody sent me something that was just atrocious, and I did my best to kind of, you know, rewrite and recast it into something that would be understandable and actionable. I thought, oh, I'm doing health literacy. It's like, no, man, that's just such a small component of it. And you know, you're right. There are what I am encouraged by is that there are so many more people who are becoming aware of the concept of health literacy, understanding its impact, its breadth, and really the power that it has to mediate and change things. You know, your first session with the, you know, on the policy and the big policy win that you had there in Maryland is so exciting, because these are the kinds of things that I think we're able to do now. I think 20 years ago, I'm not so sure you could have done that. I think these issues of health equity, health literacy have finally started to bubble up to a point where we're getting a critical mass here. And what I'm excited about is that we, as the health literacy community, are really in a position to be influencers in this whole discussion, in this whole arc of where, you know, where everything is going in healthcare and health equity, and in some of the larger things as well. You know, and again, Janet touched on a lot of these, the notions of diversity, equity, and inclusion. A lot of people get that thrown at them in their workplace, and it's like, okay, here's the boxes I got to check. No, man, it's way more than that. This is about really caring and putting in policies and practices and the things that you do on a daily basis to really make sure that you're achieving these things. And I think we, as the health literacy community, as you said, Cynthia, we are really positioned to be able to do this. And I think not only this conference, but I think a lot of the conferences that are going on now, what I feel like is that we're talking about the big issues with a capital B, and we're asking the big questions. You know, you and I, I'm sure I'm way older than you are, but I know we're sort of like, okay, in that last stretch run of our career, what is it that we want to accomplish? And I know you and I, we've done some great collaborations together, and I hope we continue with those going forward. But yeah, I mean, we're, you know, here at my organization, I know we're doing a lot of things that I think are really great and innovative. I know the Horowitz Center, you guys are doing some great things. I love seeing a lot of the programs and initiatives and efforts that people are doing at a community level, at a governmental level, at a health systems level, at an academic level, in research, and all of these other areas. And I got to say, it is heartening to see what is going on, and I just love that we, you know, continue to share these things. So I would just ask everybody, please continue to share, please continue having these conversations, keep that networking going up. And we have an ability to really change the world here. So I don't know if we have time for some questions, or
well,
if you guys
can I make one other observation? I think one thing, you know, we call this the policy and practice conference, right? But we also had a lot of research translation at this conference. A lot of my UMD colleagues were presenting their work, as well as some researchers from some other universities. But it was intended for, you know, translation into practice, right? So these were not your kind of standard scientific presentations with lots of graphs and charts and numbers and, you know, p-values, right? We're very clear with the speakers, like, this is an opportunity to take your research and to present it to people who are going to put it into practice. And on the sessions that I was in, I really saw that happening. So I also think we innovated even more than usual on the science communication side of this, because I think we had a lot of people really translating research into practice, which is, I know, something you and I are both passionate about.
And I just, a very quick plug here. You have in my colleague here, Cynthia Bauer, the practice editor of our online peer-reviewed open access journal, Health Literacy Research and Practice. So any of you who have innovative work that you're doing either in research or practice or policy, that really, that three-legged stool that really comprises a way that we advance our discipline of health literacy, please reach out to Dr. Bauer. She would love to see an article from you, or at least a query letter saying, I'm thinking about this article. We did this, we did that. How could we do that? It's really about not only what you do, but how, to the extent that you can share that, and that these things can be done again and replicated and implemented in other settings. Because if you can move the needle, let's help somebody else move the needle as well. Yeah, that's, I think that's kind of my takeaway message here. Let me just look and see if we have any other. Somebody asked, where can I find the presentation evaluations? Can't seem to find it. You will be sent that. Everybody, after the conference closes, you'll get an email, I think probably within an hour or two, for those evaluations. And yeah, please fill those out. We absolutely read every single one of those. Let us know what we did right, but absolutely let us know what we did that wasn't so right, or what you'd like to see in subsequent conferences. And we're here for you guys. I mean, we're certainly not doing this just for ourselves. So Cynthia, any other closing comments? We just got a couple minutes left here.
I think, this is such a transitional moment. I'm working on a new project here at UMD. This is pulling together faculty from, I don't know, about 10 or 12 different disciplines. And it's related to some, post-pandemic issues. And one of the things I've really just been reflecting on is the amount of destabilization that we've all experienced over the last few years. I mean, really every part of our lives have been destabilized in some way, shape, or form. And, this is a conference about communication, about information, about trying to make things more understandable and useful for people in their everyday lives. So I think there's just a lot of work to be done to help bring a little bit of stability and progress, right? So everybody has agreed, or most people agree, they don't want to go back to the way things were circa 2019. But it won't be enough just to stabilize, but we do have to have a sense of like where we want to go. And I do think people who are in this business of communication, information, we know we need to listen to the people we're trying to reach. And so I think we're in a good place to put all of those insights into practice. So I would just encourage you all to stay part of the broader health literacy community. You guys run such a great listserv. If you're not a member of the IHA Health Literacy listserv, please join. That's a great way to find others, like-minded people. I'll put in a plug for your Solution Center, right? The Solution Center is a great place for all kinds of resources. We try and put a lot of information on the Horowitz Center website. So there's lots of ways to continue this and keep refreshed and boosted over the year until IHA brings you their conference next May. So
great. Thank you, Cynthia. And I just put the link in there. If you want to become part of that discussion list and part of the broader community, it's free, no charge, healthliteracysolutions.org. Cynthia, what's the URL for the Horowitz Center?
I think it's, I should know that, but I'll
You
put
should
it
know
in the
that.
chat.
We will email Cynthia. She can get that to you. Or
I will put it in the chat.
But thank you all so much. We really appreciate it. Enjoy the rest of your weekend. We're looking forward to hearing back from you on your evals. Thank you. Take care. Appreciate you joining us. Bye now.
Bye-bye. Thank you, everyone.